Our mission for this deep dive is to map out the unique risks, the really surprising biological mechanisms, and some of the tough diagnostic challenges.
We're talking peripartum, metabolic, and stress cardiomyopathies.
And what's so fascinating here is just the sheer diversity of the triggers. You have pregnancy, which is this state of profound hormonal change.
Then you have something like a severe dietary deficiency.
And then a massive adrenaline dump from emotional trauma. And yet, somehow, they all converge on the same target: the heart muscle.
It really makes you think, doesn't it? It poses a big question for you, the listener. How much is the heart just a very sensitive barometer for the body's overall systemic balance or distress?
So our focus is going to be on the clinical reality, the genetics underneath, and of course the prognosis for recovery.
Right.
Let's start with one of the most acutely challenging conditions, one that's linked to maybe the most profound physiological state a human can experience: Peripartum Cardiomyopathy, or PPCM.
PPCM is essentially new onset heart failure that's directly tied to pregnancy.
And when does this condition typically strike?
By definition, it develops during the last trimester, or actually more often within the first 5 to 6 months after delivery.
So right when the focus is on the newborn.
Exactly. It catches everyone off guard. Statistically, most cases pop up within those first 2 weeks post-delivery. And while it's rare, it's not insignificant. We're talking somewhere between 1 in 1,000 and 1 in 4,000 deliveries in the U.S.
And the risk factors. They point to something more than just typical cardiac risk. I'm looking at older maternal age, increased parity, so multiple previous pregnancies.
Twin pregnancies, which add even more strain.
Right, and even things like malnutrition or certain drugs used to delay premature labor. What's really critical, though, is that up to half of PPCM cases happen alongside hypertensive disorders like preeclampsia.
And that leads us straight into a huge diagnostic hurdle.
How so?
Well, PPCM presents with all the signs of congestion and fluid buildup. You need an LVEF, that's the ejection fraction of 0.45 or less for a diagnosis. But late in pregnancy, what are the common complaints?
Swelling.
Shortness of breath.
Exactly. Edema and dyspnea, they're so often just chalked up to the pregnancy itself. So the real diagnosis can be missed, or at least delayed.
So what are the red flags? What tells a clinician, wait, this isn't just pregnancy? You have to look for the objective clues. Things like elevated BNP levels, that's a stress hormone from the heart, or elevated troponin, which signals muscle injury. But honestly, the most fascinating part is the mechanism behind it all.
The vasculohormonal model.
Yeah.
Walk us through that. How do hormones literally attack the heart?
Okay, so the core of it is a damaging interaction between the placenta and hormones. We all need something called VEGF, vascular endothelial growth factor. It's critical for blood vessel health.
Yeah.
During pregnancy, the body produces high levels of an inhibitor of VEGF, this thing called SFLT1, and high levels of SFLT1 are a really bad sign in PPCM. It basically cripples the body's ability to maintain vascular and cardiac health.
So it's actively blocking the repair signals.
Precisely. And on top of that, the nursing hormone prolactin gets involved. An abnormal fragment of prolactin seems to decrease the vascular response during periods of intense oxidative stress.
So this is an active area of research.
Oh, absolutely. There are trials right now using bromocriptine, which is a prolactin inhibitor, to see if they can shut down that abnormal signal and reverse the disease.
That suggests the hormonal environment is the trigger. But I'm guessing there's often a genetic vulnerability there to begin with.
You nailed it. The stress of pregnancy is often just the environmental trigger that unmasks an underlying condition. We find that about 15% of women with PPCM have these truncating mutations in the TTN gene.
And that's the gene we see in other types of cardiomyopathy, isn't it?
It is. It's very common in other forms of dilated cardiomyopathy. So for these patients, pregnancy isn't the sole cause. It's more like the accelerator that reveals a pre-existing genetic weak spot.
Now, when we look at prognosis, the recovery rates are often pretty positive. Somewhere between 50 and 80% of patients get their LVEF back up to 0.50 or higher.
Usually within about 6 months, yes.
But we have to talk about the demographic risks here because the sources are very clear on this.
This is a critical point. Recovery is much less likely if the initial ejection fraction is really low, say below 0.30, or if the diagnosis comes late, more than 6 weeks postpartum.
And there's a racial disparity.
A huge one. The risk of PPCM is 4-fold higher in Black women, and their recovery not only takes longer, but it's also less likely compared to white women. This is a profound disparity that just screams for public health intervention.
A 4-fold risk, that's a massive clinical signal. Shifting gears to management. What are the treatment specifics, especially when you're worried about fetal safety?
Initial treatment is all about stabilization. Usually that means loop diuretics to get the fluid off. But pre-delivery, there's a huge do not do. Renin-angiotensin system inhibitors are an absolute no-go. They have severe adverse fetal effects.
So you have to use alternatives.
Right, you manage blood pressure with things like hydrolysine and nitrates. But postpartum, once the mother is stable, the game changes. You can use standard heart failure meds, metoprolol and enalapril, spironolactone. They're generally compatible with breastfeeding, which is great. But, and this is important, if the LVEF stays below 0.35, that patient needs to be on anticoagulation for at least 6 weeks.
Because of the risk of a clot.
A huge risk. The sluggish ventricle is a prime spot for a thrombus to form, which can lead to a stroke or other embolic events.
All right, so moving from that acute hormonal stress of PPCM2, let's talk about chronic systemic imbalances, metabolic causes. We know thyroid function tests are routine in heart failure screenings.
And for good reason. The thyroid-heart connection is profound, especially when it comes to electrical activity. Hyperthyroidism should be high on your list if a patient shows up with new onset atrial fibrillation or VTAC that's hard to control.
And here's the irony. A lot of the time, the thyroid problem is caused by the treatment itself.
Exactly. The most common cause of a thyroid abnormality in a cardiac patient today is probably the antiarrhythmia drug amiodarone. It's loaded with iodine and can easily throw the thyroid out of whack.
So you give a drug to help the heart, and its side effect creates a condition that stresses the heart even more.
Precisely. And if you have underlying heart failure, adding hyperthyroidism on top is, well, it's a dangerous combination. You have to titrate the antithyroid meds very carefully, often in the hospital, because a rapid metabolic shift can cause a fatal decompensation.
Beyond the thyroid, the sources mention some rare but really dramatic endocrine causes.
Oh yeah, like pheochromocytoma. This is a tumor that just dumps massive, uncontrolled surges of adrenaline into the system.
What does that look like clinically?
Wildly unstable blood pressure and heart rate, palpitations, postural hypotension. It's rare, but if it's the cause of the cardiomyopathy, the cure is surgery. You take out the tumor and the heart can recover.
And what about things like very high renin states?
That's another one, often caused by renal artery stenosis. It leads to this highly erratic vascular tone, which can depress the ejection fraction and cause these really labile symptoms. Sometimes it presents as flash pulmonary edema,
where the lungs just fill with fluid very quickly.
Instantly, due to these sudden systemic shifts.
If we pull back to the bigger picture of diet and lifestyle, diabetes and obesity, we know most heart failure in diabetic patients comes from coronary blockages, but there's an intrinsic cardiomyopathy there too, right?
There is, and it stems partly from insulin resistance and the buildup of these things called advanced glycosylation end products, or AGEs. They directly impair the heart muscle's ability to contract and relax.
So that's why diabetes is such a common factor in heart failure, with a preserved ejection fraction.
Right, along with hypertension, age, and female gender. That's the classic profile.
And obesity itself. We accept it as a cause, but what's the actual mechanism?
It's a couple of things. Obesity is associated with impaired excretion of volume, so that there's just constant increased wall stress on the heart. But critically, fat tissue rapidly clears natriuretic peptides.
And those are the body's natural hormones for getting rid of fluid.
Exactly. They're the body's protective mechanism, and it gets blunted. The good news, though, is that if an obese patient has systolic dysfunction without another clear cause, effective weight reduction can lead to a major improvement in EF.
We even see that after bariatric surgery.
We do, but it's important to remember that surgery carries its own risks. Post-op deficiencies in, say, calcium or phosphate can be incredibly dangerous for a struggling heart.
That's a perfect segue to nutritional deficiencies. Rare in developed countries, but dramatic when they happen. Let's talk about the most famous one, beriberi heart disease.
Right, beriberi, caused by a thiamine deficiency. You see it in chronic alcoholism, severe malnutrition, or just diets of highly processed foods. What's so remarkable about beriberi is how it starts.
How so?
It begins as a high-output heart failure. The heart is pumping a huge volume of blood, but systemic demand is so high it's still not enough. Eventually, it progresses to a low-output state.
And the true nugget of knowledge here is the diagnosis.
It's the treatment. Thiamine repletion, just giving back the vitamin, leads to a prompt, often complete, and curative recovery.
A simple vitamin pill reversing severe heart failure. That's incredible.
It really is. And we see similar critical roles for other elements. Selenium deficiency causes Keyson's disease. And you can't ignore calcium and phosphate. They are absolutely essential for contraction and energy transfer. Severe heart failure from low calcium can respond to vigorous repletion, though it takes days or weeks, not hours like with beriberi.
We can't move on without touching on hemochromatosis, the classic genetic environmental storage disease.
Yes, excessive iron storage. And while historically we thought of it as a restrictive cardiomyopathy where the heart gets stiff, the sources confirm it often first presents as a dilated cardiomyopathy. The muscle weakens and stretches.
It's tied to the HFE gene, but it's not purely genetic, is it?
Not at all. Up to 10% of the population carries a single copy of the gene, which suggests that environmental factors, especially things like alcoholism, are major drivers in whether or not you actually get the disease.
And what does all that iron do to the heart?
The excess iron gets deposited in the heart muscle cells, a condition called cardiac siderosis. These deposits just wreck the internal architecture, especially the mitochondria, and they starve the cells of energy.
How do you diagnose that?
You look at serum iron and transferrin saturation. The thresholds are over 60% for men and around 45–50% for women. But MRI is really the gold standard now for quantifying the iron load in the heart tissue itself.
And like beriberi, if you catch it early, it's highly treatable.
Very. The treatment is direct. Repeated phlebotomy, literally drawing blood to pull the iron out, or using iron chelation drugs. It's a diagnosis you do not want to miss because treatment is life-saving and can actually reverse the damage.
Okay, to wrap up, let's pivot to the most dramatically named condition of all. Stress-induced cardiomyopathy. The broken heart syndrome.
Yes, Takotsubo syndrome. The official name is apical ballooning. It typically happens in older women after some kind of sudden, overwhelming emotional or physical stress.
Brief, major surgery.
Severe illness, anything like that. And the name Takotsubo is just fantastic. It comes from the unique shape the left ventricle takes on.
Which is?
The ventricle balloons out, but the base continues to contract forcefully. And this shape looks just like a Takotsubo, which is the narrow-necked jar that Japanese fishermen use to trap octopuses.
So how does this mimic a heart attack? And what's the key difference?
Well, patients present exactly like they're having an MI. Chest pain, dramatic ECG changes, maybe pulmonary edema or hypotension. The critical difference is when you look at the heart, the dysfunction extends beyond the territory of any single coronary artery.
So it's not one blockage.
It's not a blockage at all. It's a systemic hit. That massive adrenaline rush seems to cause chaos in the nerve signaling, leading to diffuse microvascular spasm or just direct catecholamine toxicity to the muscle cells. It's like the muscle is temporarily poisoned by stress.
What's the prognosis and management for something like this?
The dysfunction usually resolves pretty quickly, often within days to weeks. There aren't any proven therapies, but we manage it like acute heart failure. Nitrates for pulmonary edema, maybe some alpha and beta blockers if the patient's stable.
So a good outcome, despite the dramatic onset.
Generally, yes. The long-term prognosis is good, but we have to be clear, the in-hospital mortality is similar to a real heart attack. Interestingly, the lowest mortality is linked to triggers that are purely emotional versus physical ones like sepsis.
Is there a risk of it happening again?
There is. The recurrence rate is about 10% over a lifetime, maybe 2% per year, so long-term monitoring is still key.
What an incredible survey. I mean, today we've covered 3 major pathways to heart failure that have nothing to do with a blocked artery. We looked at the acute vascular hormonal stress of PPCM,
the slow systemic toxicity of endocrine and nutritional problems,
and the immediate dramatic effects of shock and Takotsubo. These sources really confirm that the heart is just incredibly vulnerable to stressors we so often overlook.
And I think the ultimate takeaway here is the importance of a precise diagnosis. For so many of these conditions, beriberi, hemochromatosis, understanding the specific root cause leads to highly effective, sometimes completely curative treatments. That understanding is everything.
Thank you for joining us for the deep dive. We'll see you next time.